Greetings from Orchidia Pharmaceutical. I hope you, your family, and all your beloved ones are safe and in good health. I'm going to talk about dry eye patient, especially who is associated with itching. Orchidia offers the integrated solution from Orca-P-Post and PolyFresh Extra. Orca-P-Post is anti-itching and anti-allergic agent, which is not only has exceptional antihistamine effect, but also has a novel special mechanism as anti-itching agent by inhibiting nitric oxide secretion at nerve endings. The second arm of our solution is PolyFresh Extra, which is a unique combination that gives extra hydration effect and balancing the tear film osmotic pressure, in addition to the anti-inflammatory effect of glycerol. Thank you for your time.
Dear colleagues and friends, it is an honor to moderate this webinar about macular hole surgery. Tonight we have distinguished speakers, starting by Professor Sherif Sheta, Cairo University. He is my mentor in vitreoretinal surgery, and Professor Dr. Muhammad Mughazi from Ain Shams University, Professor Dr. Ahmad Abdelhadi from Alexandria University, Professor Dr. Ahmad Souka, Alexandria University, Amir Ramadar, Alexandria University, Dr. Muhammad Hassan, lecturer in Alexandria University. We are going to discuss different techniques of macular hole surgery, how to avoid complications, how to deal with the refractory macular hole in idiopathic, traumatic, myopic, and diabetic macular holes. We're going to start with Dr. Muhammad Hassan. He's going to make an introduction about macular hole surgery. Okay, Dr. Muhammad, go ahead, please.
Thank you, Dr. Samir, for allowing me to share in this great event.
Share your screen, please.
Yes, I'm. It's okay now, shared with everybody?
Yes.
Yes, okay. Primary macular hole is a common idiopathic macular hole caused by vitreous extraction on the fovea from abnormal vitreous separation, while other causes of secondary macular holes includes other pathologies, such as blunt trauma, high myopia, macular telangiectasia, Alport syndrome, and others. Regarding the incidence of macular hole, the prevalence of macular hole in the literature is variable. In most of studies, it ranges about 4 cases per 1,000 cases, with a female to male ratio about 3:1, and it's a bilateral disease in 11.7 of cases with a mean age of presentation of 70 years old. The main rule in the pathology is for the ILM, which is a scaffold for proliferation, causing tangential traction around the fovea, resulting in a full thickness macular hole, which also contribute to its enlargement. A lot of classifications are proposed for macular hole, the most important of which is the OCT classification and the International Vitreomacular Traction classification, where stage 0 states for a perifoveal detachment of the posterior hyaloid with normal foveal contour. Stage 1 is divided into 1A, impending macular hole, where there is a perifoveal detachment of the posterior hyaloid and the foveal cyst in the inner fovea. While stage 1B states for a perifoveal detachment of the posterior hyaloid and the foveal cyst extending to the outer retina, causing a break in the photoreceptor layer. In stage 2 macular holes, the hole is of variable size, with partial deroofing of the cyst and an operculum, which is still attached to the edge of the macular hole, and a partial detachment of the posterior hyaloid, but attached at the operculum. In stage 3, as we can see, it's a macular hole of variable size. The posterior hyaloid detaches from the macula, often containing operculum, but still attached to the optic disc, while in stage 4, there is a complete separation of the posterior hyaloid. Preoperatively, we should take care of the hole form factor and the macular hole index regarding the prognosis. If the hole form factor is more than 0.9 and the macular hole index is more than 0.5, the macular hole has a best chance for surgery. Other preoperative prognostic factors include the type of hole, the base diameter and the indices, the edges of the hole, duration of presentation, and the outer retinal biomarkers. 50% of stage 1 macular holes can regress spontaneously compared to 40% with progression, while in stage 2 it's 15% to 75%, in stage 3 it's 5 to 50%, and in stage 4 it's 2 to 20%. The overall risk to a normal fellow eye is in the region of 5 to 10% over 5 years. Without the PVD, it's about 20%, while the risk is extremely small if PVD is present. Post-operatively, we have different type of closures. The U pattern carries the best prognosis, followed by the V pattern, while the W pattern carries the worst prognosis, where there is a foveal defect of the neurosensory retina. Preoperatively, we should do OCT to differentiate macular pseudohole and a lamellar macular hole, both of which having an epiretinal membrane. But in a macular pseudohole, there is increased perifoveal thickness with normal or slightly increased central foveal thickness, while in a lamellar hole, there is near normal perifoveal thickness with a thinner central foveal thickness and intraretinal splitting. Lastly, what is the basic steps for treating macular hole surgically? We go for vitrectomy, phacoemulsification first, then complete vitrectomy with complete separation of the posterior hyaloid, ILM peeling after staining, shaving of the vitreous base, and using the appropriate tamponade. The most crucial step for macular hole closure is the ILM peeling, and here we are discussing variable techniques of ILM peeling. Let's start with the original one. This is the most, we can say the original one or the first one, which is the Raxis technique, just removing the ILM like doing the capsular access, just in a Raxis manner. This is the first one. Then we shifted to the inverted ILM flap. And this is a diamond dusted scraper, Teno scraper, creating an edge, and then by the Eckert forceps or an endogripping forceps, we can elevate the flap like this, and now the flap is going to be inverted inside the hole. As we can see, okay. Another technique, which is a temporal flap technique. Here the flap is elevated from the temporal side and it's everted on the nasal side without actual inversion of the flap inside the hole, just eversion of the flap towards the optic disc. Followed by fluid air exchange with slight shifting of the eye to the nasal side. Another technique, which is the free hinged ILM flap, we can do a routine macular excess, followed by elevating another flap from the edge of the ILM. The hinge is still attached to the original one on the nasal side, and the flap is inserted inside the hole. The transplant techniques include autologous retinal grafting. This is the donor area after application of laser and diathermy, followed by harvesting the graft, and under PFCL, the graft is dragged to be tucked on the top or even inside the macular hole itself. We can use anterior lens capsule, and we can use amniotic membrane transplant, and all of these techniques is going to be discussed in details with professors in the remaining of the webinar. Thank you so much.
Thank you, Dr. Mohammed, for this intro. Now, Professor Dr. Amir Ramadan is going to talk about the original inverted ILM flap. Go ahead, Dr. Amir.
Thank you. Thank you for allowing me to participate. Share screen. I talk on the inverted ILM flap for macular hole repair. The original inverted ILM flap. The concept of the inverted flap is we peel the ILM as the ILM peeling technique, but we leave a small remnant on the surface of the macular hole that is then inverted on its point of attachment over the macular hole. So when we, by doing ILM peeling, we are relieving the tractional forces on the macula, and also by the inverted ILM flap will act as a scaffold for glial cell proliferation, enhancing the macular hole closure. The advantage of the inverted flap over the ILM peeling is the very higher rate of complete macular hole closure that was reported by Mikhailovska in 210 and 214 for the large idiopathic macular hole and for the myopic macular hole, which approached approximately 100% success rate. My case was a 57-year-old female patient, had a neglected macular hole since 1 year after treatment for a branch retinal vein occlusion that did not involve the macula, and the vision was 660. The OCT, the old OCT showed a full thickness stage 3 macular hole. The patient was treated by vitrectomy, inverted flap, and gas. This is the step of the ILM peeling after staining under air using the inverted flap technique. I started by elevating the ILM flap all around the macular hole, 360 degrees, and widening the area of the ILM peeling around the inverted flap. I try to make the flap smooth so that I do not need to do a lot of trimming for the remaining edges of the inverted flap. And after that, I tried to put it over covering the macular hole. This is the most difficult step because sometimes you get detachment of the ILM when you grasp it by the ILM forceps, and sometimes it does not invert inside the hole. And then I did air fluid exchange and gas injection. 1 month post-operatively, the visual acuity improved to 0.4, and the post-operative OCT showed the ILM flap seen over the macular hole, and there is a residual very small inner retinal defect, and there is restoration of the external limiting membrane and the ellipsoid zone over the macular hole. So this shows that the inverted ILM flap technique is a successful technique. But it has its disadvantages. First, there is technical difficulty. One paper reported a 14% of cases had a detachment of the IL flap while they were manipulating it during air fluid exchange, and other papers suggested using PFC or viscoelastic to stabilize the flap during this step. Also, another paper reported that the ILM flap may migrate to the bottom of the macular hole, and the glial proliferation in the outer layer may interfere with the macular hole closure or restoration of the external limiting membrane and the ellipsoid zone. So this stimulated the same research group of the MACULAR to invent the temporal inverted ILM flap technique. And there was a study published in 2015 in which they concluded that it was as effective as the classical inverted ILM, as a classical technique, exactly. Its principle, as Dr. Muhammad Hassan said, that we get a large single layered ILM with a wide connection to the retina, removed from the temporal side of the fovea up to the edge of the macular hole and inverted to cover the macular hole. Its advantages: first, there is a decreased risk of surgical trauma, mainly to the papillomacular bundle, because this area of the retina is not touched, and there is decreased risk of dissociation of the optic nerve layer because there is no ILM peeling done. Also, it does not detach spontaneously because of its broad attachment, so it is technically easier to do. And a single layer flap that is covering the surface of the macular hole does not reach the bottom of the macular hole and does not interfere with the healing of the macular hole. But it still has its disadvantages because the ILM is not removed. There is still no relief of the tractional forces acting on the fovea. And also, in some cases in which there was a epiretinal membrane preoperatively, there was reported retinal contraction on the nasal side of the macular hole due to cellular reproliferation on the unpeeled ILM that may cause foveal deformation. And this is a case reported that after ILM peeling was done, at the 4th week, there were development of retinal contraction on the nasal side, and an epiretinal membrane was formed, causing the formation of the fovea, although it did not affect the visual acuity. So, can we get the benefit of a better macular hole closure of the temporal flap and a decreased risk of retinal contraction? I tried a technique called modified temporal inverted ILM flap. This was a case that had epiretinal membranes because it was a diabetic patient. I started by doing the standard temporal ILM flap to cover the macular hole, and then I did not stop at this step. I widened the ILM peeling more temporally, and in the lower half corresponding to the inverted flap, I started to separate the ILM, leaving a small island of the ILM so that I can do the temporal inverted ILM flap, and at the same time do ILM peeling to relieve the tractional force and decrease the risk of retinal contraction. I continued separating from the corresponding side step by step. And the last part of the ILM, I used a scissor to ensure it's completely separated from the outer ring of the ILM. Then I did air fluid exchange to the case. My take-home message is that inverted ILM flap has superior results to ILM peeling in almost all types of macular hole, and different techniques can be used successfully according to the surgeon's preference and the individual case findings. Thank you.
Thank you, Dr. Amir, about this resume about the ILM peeling. Now we are going to start with Professor Shiv Shetar from Cairo University about his topic, how to initiate safe ILM peeling. Go ahead, Professor Shiv.
First of all, I'd like to thank Dr. Samir and my colleagues from Alexandria University for inviting me to this webinar. Actually, the first part of my presentation will be about a crucial issue, which is how to initiate a safe ILM peel. We know that the ILM is the thinnest basement membrane in the body, and this is a very delicate and very close to a very precious organ, which is the fovea. That's why a safe peeling of the ILM is mandatory. And to be safe, you have certain prerequisites. First of all, use stain in all cases. And if the stain is not visible, you can re-stain again. I usually stain in a fluid-filled eye. I don't stain under air. I usually stop the infusion while putting the stain. I usually cool the stain so that it is heavier and it drops inferiorly. And actually injecting the stain is very important. I'd like to inject it with a wide bore needle so that there is no resistance, so that there is no frequently a gush of fluid that can harm the posterior pool. Always point to the optic disc and few drops of stain, and usually stain for 30 seconds and then wash or open the infusion fluid. I usually use a high magnification. My preferred is a green lens of the race type, but use whatever magnification. You can use a contact lens for better stereopsis. I usually start inferior to the macula, near a blood vessel. I avoid doing it over a blood vessel so that the pinching does not cause bleeding, or above the papillomacular bundle so that if a microscotoma occurs, it does not occur over a very precious bundle like the papillomacular bundle. And starting inferiorly is actually in your visual axis. And if a microscotoma occurs, it is in the upper field, which is not frequently visited by our everyday practice. My preferred technique is the pinch and peel using an end gripping forceps. Previously, there have been a pierce and peel where you use a sharp needle or an MVR to make a puncture in the ILM, which is, I think, risky and is not a safe procedure to do. The best way to remove the ILM after that is to create a flap. And once the flap is created, you can easily fashion the flap in a way you want, whether a macular axis, a temporal flap, or inverted flap. To make a flap, you do friction on the surface of the retina. Usually this is done by a brush, like a Teno scraper or tissue manipulator, or it can be done in a more elegant way by the serrated or flexi 27 gauge loop. The end gripping forceps, usually I prefer to have one with a broader grip so that there is less frequency of tearing of the internal limiting membrane during the peel. I'd like to have somewhat of a separation between the blades so that you can see through, so that you can safely remove the internal limiting membrane. The pinch and peel, classically you separate the tips of the microforceps in just a little distance, and you just touch the surface of the retina, and then you pinch. If you have a large separation, probably you will pinch the membrane and the retina. So the separation of the ILM forceps should be minimal. After pinching, you just elevate and rock sideways and keep an eye to the nearby blood vessels so that you make sure that you are only pinching the internal limiting membrane. And once the internal limiting membrane breaks, the color difference between the stained internal limiting membrane and the undersurface of the retina will be visible. And then you can catch the edge of the internal limiting membrane and fashion your macular rhexis. Even if the membrane breaks, you can recatch and do the rhexis. I like to use myself the 27 gauge serrated loop or flexi loop to create a flap. It's a very delicate, less traumatic, a very lightweight, it's a feathery like, and usually it is retractable so that it can go through a valved cannula without problem. And you can also adjust the length of the loop so that it can be hard or less hard. So that the more lengthy the loop is, the more flexible and the more light, the less protruded, the more firm, so that it can create a break in the internal limiting membrane. This is an example of how I start inferiorly, close to a blood vessel, just pinch and elevate and make a circular motion. And now you can appreciate the color difference between the stained and the eye-stained ILM. Sometimes petechial hemorrhage occur, but they usually go away. Another way is to use a Tano scraper close to a blood vessel and then grasp, or use the flexi loop, and which is, I think, the best way to create an internal limiting membrane flap. And once the flap is created, I think the rest of the procedure is easy. The flap, I usually like to extend the loop so that it is very elastic and less traumatic to the retina. And once the flap is created, you fashion your rhexis. In the beginning of the procedure, we used to remove the internal limiting membrane completely. After the initial cut, you do a rhexis. And usually I like to stop and recatch the edge of the internal limiting membrane to avoid its breaking and to direct it as I want, exactly like the capsular rhexis. And usually the size of the rhexis is dependent upon the size of the macular hole. So the larger the macular hole, the more that I tend to go with the rhexis to the arcade, and you can enlarge and re-enlarge. The types of the internal limiting flaps, instead of peel and remove, we realize that the internal membrane is a precious organ, so we peel and utilize. And how to utilize? By making a flap. And the types of the flap are either the inverted flap, the multi-layer flap, the hinged flap, the temporal flap, or the free flap. This is an example of a temporal flap. You start inferiorly, you make the rhexis, and then you pull the edges of the internal limiting membrane to the surface of the retina. Sometimes if it is too long, you can trim it using a low suction and high cutting rate, and you put the internal membrane into the macular hole. You don't insinuate it into the macular hole so that not to disturb the retinal pigment epithelium, but just to cover the macular hole. And during fluid air exchange, you make sure that you put your extrusion needle above the optic disc so that you don't suck the flap of the internal limiting membrane. Another way is to do a multi-layer flap, where I gather the internal limiting membrane from different quadrants and collect them over the macula. This will like a fold or an envelope, like Dr. Murtada have usually used to say. This is a way to close the macular hole, and I usually resort to the multi-layer flap in large and chronic or myopic macular holes. The hinged internal limiting membrane flap use the edge of the internal limiting membrane at the hinge. Here you can see an observation that the part that is removed from the internal membrane turn whites, like you see it. You see the color difference between the peeled and the freshly peeled, and after a while this color changes. And this is the hinge of the internal limiting membrane. I like the hinge to be on the temporal side so that during fluid exchange, the wave of the suction tends to keep the flap into the macular hole, not otherwise. If the membrane, if you lose the internal membrane, or in recurrent cases, you can go to the edge, create a flap, and close the infusion so that the flap does not move into the eye, and you drag it and put it into the macular hole. And this is what we call a free internal limiting membrane flap. Nowadays, we are more and more going to do a sort of a temporal flap. And as we have said previously, the temporal flap has advantages is that you do not remove any of the internal limiting membrane. You will just create a large flap on the temporal side, you drag it, you stop at the edge of the macular hole, and you reflect the flap over the macular hole. And during fluid exchange, this is the natural tendency for the flap to stay on the surface of the macular hole. And the beauty of this technique that it is in conversion to the peel and invert, you see in the peel and invert a glial plug. And this glial plug usually may hinder the natural resolution or restoration of the ellipsoid and outer segment structure. But in the peel and cover, as you can see, the cover flap allows the retina to heal smoothly without the presence of the glial plug. So I think that a peel and invert is less physiological than a peel and cover. Even in the temporal flap, if the flap moves, you still have the flap in the eye, so that redo is very easy. You just go again and just reposition the flap over the macular hole. You don't have to create a new flap. So that in brief, I think that the multi-layer flap can be used in large chronic and myopic macular hole. My preferred technique now for the idiopathic macular hole is the temporal flap because I think it is least traumatic. You avoid the papillomacular bundle, you do not lose the flap, and you can easily redo if the flap moves. Another type of macular hole is the traumatic macular holes. And traumatic macular holes I see in this case, usually this is a young patient with a zonular dehiscent and some early posterior cortical cataract, and you do separation of the posterior hyaloid. You can see here the expanding wave of posterior hyaloidal separation. Actually, I don't like use to triamcinolone stain during posterior hyaloid separation because I think it hinders the visibility of the posterior hyaloid separation. So I like to use it without temporal. Then I use a Thanos scraper to create a flap. In the same way, I just create the flap, fashion the flap, grasp it near the edge, and every now and then stop and recatch at the edge of the internal limiting membrane to make a flap. And if the flap tears like it happens here, still you can steal a residual part that you can use and inverts, like you see in this case. And you can even enlarge side. If you see this flap is not stable, you can do another cover flap from the nasal side. So there is an inverted part and a cover part to assure that complete closure of the macular hole. In traumatic macular hole, the visual recovery depends upon the collateral damage. Because, you know, in trauma, there may be choroidal rupture. As you see here, on the left side, you see a slide with multi-centric choroidal ruptures. On the right side, a large choroidal rupture close to the macular hole. And in these cases, you don't expect a full visual recovery. This is a case of a large macular hole from trauma with choroidal rupture, as you can see here, and you see the large base of the macular hole. And actually, after vitrectomy, with a temporal flap, you can see here the cover flap, the macular hole closed completely. Still, the choroidal rupture is there, but the macular hole closed. Luckily enough, the macular hole was not foveolar. It is just juxta to the fovea, and that's why the patient have regained nearly a very good vision. This is a rare case of a macular tear, not a macular hole. A blunt trauma resulted in a U-shaped tear, which is very peculiar and very rare in the macular area. We are accustomed to use U-shaped or flap-shaped tear in the periphery, but in the macula, this is very exceptional from the huge extent of the trauma. This patient presented with mild vitreous hemorrhage that was removed during surgery and a large tear in the macular area with a flap. My technique in this case, after making sure that I removed all the internal limit or the posterior hyaloid with triamcinolone because of the trauma, I used stain. And the stain I use is the brilliant blue stain, which is the best stain in my hands. I create a large flap on the nasal side. Then I dragged a flap here, dragged it from the nasal to the temporal, not from the temporal to the nasal because of the shape of the U-shaped tear. And I covered the U-shaped tear and take another flap to cover the base of the retinal tear and put a viscoelastic material to stabilize the flaps on the surface of the macula. And after that, actually, this macular tear closed. The patient suffered from metamorphopsia, but the macular tear closed. So still, if you have a large macular hole, you can close it with the island flaps. Idiopathic macular hole can occur in myopic patients, but they are somewhat different. The difference is that there is difficulty in visualization due to chorioretinal atrophy and sometimes posterior staphyloma. The posterior hyaloid in myopic eyes, as you know, is more adherent, is more posteriorly inserted. The internal limiting membrane is thinner, fragile, and tends to break. And the clue in these cases is to stain and re-stain till you have a good visualization. Use an ILM forceps is mandatory, especially with a long handle so that it can reach the posterior pole with a broader grip because there is a tendency for the ILM to break. It's better to use a multi-layer ILM flap to assure closure of the macula. This is a patient, as you see here, with a macular hole without detachment in a myopic eyes with chorioretinal atrophy, where I create a flap from the nasal side. Then I do another rhexis and create a flap from the temporal side and collect both flaps into the macular hole. And then do fluid air exchange. During fluid exchange, you should avoid putting the extrusion needle close to the macular hole so that not to suck the flap. And this on the left-hand side, you can see the color picture of the patient. Actually, 5 days after surgery, you can still hear the edge of the air bubble and the macular hole looks at closed. And 1 week later, the air bubble have disappeared and actually the macular hole closed. And this is the OCT picture of the same patient. You can see here the ILM cover flap, and there is due to inversion, there is glial plug closing the macular hole. Usually this glial plug disappears within months with the restoration of the outer segment. So in highly myopic eyes, the multi-layer flap have a best chance for closure of the macular hole. To make things more difficult, sometimes macular holes or in the myopic patient occur in the pediatric population. And these cases, the posterior hyaloid is very adherent, as you can see here. And during separation of the posterior hyaloid, due to posterior insertion of the vitreous base, usually you cannot peel the posterior hyaloid to the far periphery, and you are obliged to stop close to the equator, otherwise you'll create breaks. And you can see here that there is resistance for spread of the posterior hyaloid separation to the periphery, and the posterior hyaloid is very firm and very elastic. So the safest thing in this case is just to trim the posterior hyaloid and then use stain to close the macular hole. As you can see here, I use here a sort of a flap to cover the macular hole in myopic patient, and this flap is a sort of a temporal flap that was used to cover the macular hole. And during fluid exchange, as you can see, you put the extrusion above the optic disc away from the macular hole, and usually the gradient fluid keeps the flap sitting on the macular hole, and the chance of disruption of the flap is very low. So I thank you very much for your interest.
Thank you, Professor Schlief, for this resume about different techniques of macular hole surgery and traumatic and myopic macular hole. I think it's very interesting, and we have a lot of questions. We're going to postpone the questions after Ahmed Abdelhadi present his topic about perfect anatomical outcome in ILM peeling. Dr. Ahmed Abdelhadi, can you?
Okay. Shukran. About the invitation, Dr. Samir, I'm going to start. A lot of the literature have been presented by Muhammad, and a lot of literature and techniques have been presented by Dr. Sharif Shita, our dear professor from Cairo. So I'm going to share this case to raise a question about the inverted flap technique and its effect on functional outcome. This was a 59-year-old female with 3 to 6 months history of diminution of vision, a metamorphopsia in the left eye, on clinical examination of the left eye, nuclear cataract, 660 of vision, and a full thickness stage 3 macular hole. This is I did phaco-vitrectomy with the patient after core vitrectomy, staining in a fluid-filled eye, then doing the usual inverted flap technique, 360-degree peel, and leaving the connection of the ILM to the edge of the hole, and then shaving of the peripheral vitreal base, shifting air, and then this was the picture. 3 months post-operative, the visual acuity on the left-hand side was 0.2 only. As we remember, the patient started with 660 vision. And this is the OCT of the patient. As you can see, the ILM inverted flap over the surface of the retina. The retinal layers are not so continuous. The ELM and the IOS-OS junction is not so continuous. After a year, and this is only this month, the 10th of August 2020, the patient is still 0.3, and I expect the patient, and this is a question for all the dear panelists, you expect the patient of 660 with stage 3 macular hole was just been there for about 3 months to end with 0.3 vision. In my hands, it usually they usually gain more vision. And this is the OCT of the retina, and we, as you can see with this enlarged or highly magnified OCT, still the retinal layers or the internal architecture are not normal, in spite of the fact that the ELM and the IOS junction is continuous, but the vision remained at 0.3. And when I searched the literature, there was a comparative study between the efficacy of inverted ILM flap versus the usual technique of internal limiting membrane peeling in large macular holes, which was a systematic review in 2020. And they found that the inverted flap had a better anatomical outcome than the ILM peeling in large macular holes. the flap technique had a significant visual gain in the short term, but the limitations in visual recovery at a long follow-up was found. And our dear friend, Professor Cyrus Sharoff, published a paper in Clinical Ophthalmology in 2019 about the inverted flap technique, how to select the patient and special consideration. And he found, and he published or stated in his conclusion, I quote, "Surgical manipulations to tuck the ILM flap into the hole could potentially damage the retinal pigmentary epithelium at the base of the macular hole and compromise visual results." And this is my idea why the visual results of this patient didn't improve that much. And the rest of the cases are going to present later. So I ask my dear professors, what do you think about, have you been faced by a case where you felt that the functional outcome was not perfect? Tursheta, what's your say about this? Have you been faced by a case where the functional outcome of the patient was not perfect, was not as you expected, and you blamed the inverted flap technique, or because of the, and of course you have failure of retinal architecture to regain to the normal after a long time, 6 months or 1 year, or haven't you had this impression whatsoever?
Theoretically, I don't like to do any plug inside the macular hole. I think that this may hinder the natural healing of the outer retinal layers. So I believe now that a cover flap is better than an inverted flap. Actually, the inverted flap can cause a glide plug. It will lead to anatomical success in the early period, but the visual recovery will be delayed because it takes few months for the glide plug to disappear with the restoration of the natural outer retinal layers. On contrast, I think the cover flap just allow at a scaffold that helps creeping of the normal outer receptor and photoreceptor so that the healing is more normal and more rapid. So anatomically, yes, you can, with the inverted flap, can cause early closure, but the visual recovery, I think, is delayed. In the cover flap, you can have an early anatomical results and early visual recovery. Also, it depends upon the preoperative visual acuity and the duration of the macular holes and the state of the retinal pigment epithelium and whether it was touched during surgery or not. So I think all these factors may affect the natural recovery on the visual effect.
Okay. So Samir,
Rahmat, did you finish your presentation?
This one, I have another cases later on.
Okay, Professor Sharif, I want to ask you, what is the preferred size of the flap? Is it enough to make it to 1 disc diameter? It's better to make it larger. You can extend it to till the arcades. You think this give us a better healing, or what's your preferred size of the flap?
You mean the size of the ILM peel or the size of a
yes. No, ILM peel.
Usually, I like to have a 2 disc diameter of ILM peel around the maxilla. I usually think this is usually sufficient. For a chronic and large macular holes, I may go up to the arcades. But remember, I like to keep a reservoir of the internal limiting membrane in the periphery. In case that there is failure of closure, there is a reservoir of ILM that can reuse. So that I don't like from the start to have a very large ILM, because usually this may not be needed. And at the same time, you don't have a reservoir of the ILM that you can reuse in case of failure of closure. So the usual is diameter.
Don't you think the larger the ILM, the size, it will induce more complications like Domfell and Sonfell and all these complications, and the smaller the size is better?
You know, and it's always have been my, God have not created anything haphazardly. So the internal limiting membrane has a purpose, and I don't remove it until it is pathological. So in the periphery of the internal limiting membrane of the macula, I don't think that it causes much glial proliferation or tangential traction. So I think 2 disc diameter around the macular hole is enough. The larger you go, the more you expose the bare retina, the more you disrupt the gangliosine connections, and probably the more physiological effect on the retina. So I would like to do the least that is needed to attain the best vision.
Ahmed Abdel Hadi, what is the preferred site to start dialim flap? Do you prefer to
actually, like Dr. Sharif,
at what site? What is the preferred site?
Like Professor Sharif has just mentioned in his very elegant presentation, I like to start with inferior, infratemporal or infranasal, away from the blood vessel, so that if I have a pinch to the retina, scotoma, it is in the superior field, which is not very disturbing for the patient in his daily life, and about 1 disc diameter away from the outer edge of the macular hole.
Do you think that if you start at the papillomacular bundle, it is risky for more trauma and more field effect?
Yes, I think avoiding the papillomacular bundle as much as possible. Actually, I've adapted the temporal flap technique. I don't like to do an ILM peeling in the papillomacular bundle, and this I feel that the visual acuity is better. Of course, we have to have a study including multifocal ERG or microperimetry to see the effects of this ILM peel on this area in the visual field. But I feel that the papillomacular bundle should not be tampered with. A question for you, Dr. Samir. Do you feel that all lights is the same, or do you like to use a special light while you are doing the ILM peel? I know you have all the wavelengths, the gadgets, and all the. Do you shift to amber yellow, for example, or something, or do you use the normal white light?
I use the normal light. I don't use the amber. Okay, because ILM peeling right now it takes shorter time than before. It takes less than 2 minutes. Okay,
yes. Even in difficult cases in high myopes, you don't make benefit of this nice wavelengths. The amber yellow makes the difference between the peeled and the unpeeled area accentuate. You don't feel this. You don't feel this.
Actually, I don't feel the amber. I tried all the filters, but any difference between them.
You're similar to each other in your hands. Okay.
I prefer to make breaks during my technique to avoid phototoxicity. Okay. Dr. Ahmed Souka, I want to ask you about the preferred technique. Professor Sharif mentioned a lot of techniques, starting by a pinch technique, flexi loop, piano scraper, pick and forceps. What the preferred technique do you use?
Yeah, I'd like to pinch the ILM just at the above the nerve fiber layer. With experience, it's easily done nowadays. It's very important if you're starting to learn this that you start in an area where damage is least. I mean, the first cases can catch the retina, can cause bleeding, can cause some damage to nerve fiber and underlying retina. So I prefer that you go either superior or inferior to the macula. Probably inferior is better as regards the visual field, as Ahmed Abhedi mentioned. However, superior is easier for beginners to start the peel, superior to the macula, to the fovea, I mean. You should avoid the papillomacular bundle area. And I think the real message is that we discovered that removing the whole of the ILM is less of a visual prognosis than leaving part of the ILM. I mean, every one of us have tried total ILM peeling before, and now trying some remnants of flaps, whether 360 degrees flapped at the edge of the macula or temporal inverted. Obviously, leaving the ILM leads to better visual outcome. We see it in our cases. Which flap exactly, I'm not sure which one is best, but the one I use is a somewhat multi-layered inverted flap, 360 degrees peel around the flap. I don't leave the nasal ILM intact. I tried it, I started with it. Results are very good, patients are happy. I feel the outcome is good, so I'm not changing the technique up till now. I'm considering the inversion of the temporal flap only and just covering the macular hole. But changing a good outcome technique is not easy for me to choose which patient should try the first one. Obviously, they all work. I recommend not peeling the whole of the ILM, and I leave part at the edge of the macular hole of the ILM attached, and I have a feeling that there is some connection to the photoreceptors that shouldn't be disrupted totally, and it adds to the vision, in my opinion. Definitely tucking and touching the RPE in the bed of the macular hole, I'm totally against. I feel it will damage, yes, this area. It will not lead to the best vision we expect. And I don't feel that we have to plug the hole with the ILM. I feel it has to rest on the surface of the macular hole just superficially, and they close in near 100% of cases. However, some do not attain a good anatomy on OCT, as Abdelhadi mentioned in one of the cases. And yes, some of them do not give me the expected visual outcome as others. I don't have an explanation. I have a fixed technique for all of them. So I basically do the same thing. So I cannot explain why a percentage of patients give us this distorted layers at the fovea and not so perfect visual outcome. I personally don't have an explanation for this, but definitely the flap is better than the total peel, definitely.
Dr. Amir Ramadan, what is your preferred technique? Do you prefer the pinch technique, or you like to start with the pick and continue by forceps? What's the preferred technique for you?
I also use the pinch technique. It's much easier for me. And I also do a multi-layered flap. I'm now trying the inverted flap. I'm still don't have a lot of cases, and I'm still will compare the outcome in both cases.
Can I comment?
Yes, go ahead, Dr. Professor.
I'd like to ask that about you said that you do a routine phaco emulsification in all idiopathic macular holes. Actually, this is not my routine. I only do phaco emulsification if I have any hint of nuclear sclerosis. But if the lens is completely clear, I prefer to just stage the surgery and do the macular hole surgery. This have an advantage that there is less effect of gas bubble on the anterior chamber and less inflammation in the eye. The second point I'd like to discuss is the tamponade. Use air or sulfur hexafluoride. I usually now use air in most of my cases.
Can we postpone this about the use of gas? We are going to discuss this later on. Dr. Muhammad Hassan, what is the preferred size and site of ILM peeling?
الحقيقة pinch and peel technique is yeah, I like to do it in most of cases. Recently, I'm trying to do that in the temporal flap, but I don't have much cases still now to guide. But I have a somewhat a different opinion. I still up till now for very small macular hole doing the routine macular excess without any inverted flaps, because as Dr. Ahmed Abdelhadi said, touching the RPE causing a damage and delays the visual recovery. And I'm satisfied with the results in small macular hole with the routine macular excess regarding the anatomy and regarding the visual outcome. But in large macular hole, I use multi-layer inverted flap, and it's mandatory to me in high myopic eyes.
Professor Rashid.
I'd like to comment on this part. What works better with larger macular hole will work perfectly in small macular holes.
Yes,
and
yes.
Small macular holes, when I leave a flap nowadays, I'm always looking for a 6.9 to 6.6 vision. If it's a 6.12 vision, I feel something went wrong. But in previous days, small macular holes, ILM peel for a 6.18 patient. If you get 6.12, 6.9, you feel it's perfect. Nowadays, I'm aiming for 6.6 because I'm doing the flap and not the full peel. It's definitely a better visual outcome. I don't think any of us has encountered something different than that.
Professor Sheta. Sharif.
معاك.
Okay.
Let's continue with the program, Dr. Sharif, because of the time, and we can continue the discussion later on. What do you think about the...
what is the question?
The question is about you should give us some tricks how to identify the ILM and how to differentiate between the posterior hyaloid case and the ILM. Sometimes some surgeons find difficulty to identify the ILM.
So definitely the posterior hyaloid is a different membrane from the ILM. The posterior hyaloid is elastic. The posterior hyaloid is not refractile. So the texture is different, the appearance is different. So I think with little experience, you can differentiate between both. If you have any doubt, you just use triamcinolone first to make sure that you have removed the posterior hyaloid, and then use stain to identify the internal limiting mark. Actually, the stain can stain both some stains stain both the posterior hyaloid and the ILM. But if you remove the posterior hyaloid, you can see this expanding wave of the posterior hyaloid, and this is very visible even without using triamcinolone. And then you put the stain, and you can easily identify them to the lymph.
I have another tip in this, is that the ILM usually it rolls in a roll fashion, but in the posterior hyaloid it doesn't roll like this, and the ILM also have a glassy appearance which is not present in the posterior hyaloid phase. I have Professor Muhammad Mughazi just arrived, and I'm going to do my presentation. My presentation will be about autologous transplantation of ILM. In some situations, there is a failure of, in certain cases, there is a failure of ILM peeling or ILM flap. So we have to use this technique in certain situations. I have a case here with failed macular hole peeling. It was an invertical, it was an ILM peeling. As we can see, it is well delineated that there is an area denuded of ILM. I start by staining, as you can see, by BBG, and I start to fashion different flaps of ILM, and usually I keep it attached to the original ILM. I don't detach it completely because I'm afraid to be lost or to lose it in the fluids of the eye. And usually I fashion more than one ILM flap, as you can see, and keep it attached. And I like to do this technique, the autologous transplantation, under air or under perfluorocarbon. This technique of holding the ILM with the forceps and detach it and put it inside the macular hole usually doesn't work because it is crushed in the forceps, and I don't recommend this technique. But if we are going to drag it with this Thanos scraper on the surface of the retina very gently without pressure on the retina, and embedded inside the macular hole, it's better to take more than one flap and drag it with this Thanos scraper very gently, okay, and put it inside the macular hole, as you can see, okay. To keep it in its place and to avoid to being lost, it is better to inject helon, and helon by name. We don't use methyl cellulose over the retina. It's better to use helon, okay. Then this is followed by fluid exchange and sulfur hexafluoride 20%. Usually the patient is recommended to sleep on his back for 6 hours. After that, he can sleep on the face down position. This is the end of the video. Now I'm going, Professor Mughazi is going to present his talk about the temporal inverted ILM. Dr. Mughazi, can you proceed?
Yes, sure. أولا أنا آسف على التأخير، لكن إن شاء الله يبقى.
No problem. No problem.
We're happy to have you, Dr. Muhammad, and welcome to the webinar.
أنا أستأذنكم بس I have to quit and relog in عشان يطلع ال presentation. Okay.
We can continue with Dr. Ahmed Abdelhadi about myopic macular hole.
Are you going to take long, Dr. Muhammad, or can I start my presentation?
I'm ready now. Can
okay.
you see the presentation?
Dr. Muhammad is ready. Okay.
Okay. All right. So temporal inverted ILM flap, of course, has been described by Mikuleska in 2015. And since 2016, actually, this is currently my preferred practice for macular holes of different types. Just showing you a few cases here. This is the first case, stage 3 macular hole. The beauty of this technique is that you can fashion the graft according to the size of the hole. So where do you begin temporal to the hole depends really on how big is the hole. So I use to just draw a line of ILM. I remove a part of the ILM temporal to the fovea and fashion the grafts later. So I put my boundaries first, and then I fashion or invert the flap later. Technique is well known and has been shown several times. The potential advantage of this technique is that you're leaving a reservoir nasal to the fovea, a reservoir of ILM, in case there is a failure of the first surgery. The other thing is you're not manipulating the underlying retinal nerve fiber layer a lot, especially in the papillomacular bundle area, which is very precious. This can potentially decrease the field loss or the focal field loss that has been described after complete ILM peeling or complete ILM inversion. It also doesn't necessitate the use of perfluorocarbon because, as I'm going to show you, air is, when you go to air fluid exchange, it just folds into its place once you put the flute needle or the cutter at the disc. You can see here, it's fashioned now. You can see here during time of air fluid exchange, and you can see it just folds into its place gently and covers the hole. Also, you can use, since there is no bare retinal nerve fiber layer here because the nasal ILM is preserved, you can use a soft tip or even the hard tip flute needle to dry as much as you can at the end of the surgery. This helps keep the flap inverted in its place at the end of the surgery and in the first few hours post-operatively. So it doesn't dislodge, it doesn't fold back and expose the macular hole. So this is drying all around. Be patient. I usually take 5 minutes doing this just to ensure that the flap remains its place after surgery. And this is the post-operative picture. Very nicely closed macular hole. This is just 3 weeks after the surgery. There is still some interruption of the IS-OS junction, but the hole is nicely closed and the layers of the retina looks normal. This is a second case. This is a myopic patient. You can see the posterior staphyloma, and this is at the time of the surgery. You can see the same technique. Sorry for the slight defocus in this video. You know that the ILM in high myopes is kind of elastic and it's very difficult to grasp sometimes, and sometimes it shreds, which again, this technique can give you a reservoir of ILM once you need it, especially that also in myopic macular holes, you have a lot of failures. So once it's inverted, it usually remains in place at the time of air fluid exchange, like I described. There's no need to use perfluorocarbon or viscoelastic or anything of that kind to stabilize the flap in place. You can see here at the time of air fluid exchange, very nicely, it folds into place smoothly at the time of air fluid exchange. There is no dislodgement. However, this particular case, actually, this is the post-operative. You can see there is collapse of the scetic cavities, but the macular hole persists. So we went in again because we have a reservoir of the ILM on the nasal side, like you see here. Again, also, you know that the brilliant blue does not stain well the ILM in high myopes, but you can see the nasal flap is now fashioned and it's covering the hole. So you have a reservoir. Once you have a failed hole like this, you can fold back from the remaining ILM elsewhere. And this is post-operatively after the second intervention, the nasal inverted flap. This time you can see it's nicely closed macular hole. This is another case. Again, the technique is the same. Just fast forward here, but just to show you again that if you have a failure, like I did again in this case, it's a relatively large hole, relatively chronic as well. This is post-operatively, 3 weeks post-operatively after the gas disappeared. And this is during the second surgery where the nasal remaining part of the nasal ILM is fashioned and flapped as a nasal flap. Actually, the temporal flap is there, but it's kind of shrunken. I don't know why. So I couldn't fold it back again as a temporal flap, so I had to fashion the nasal flap. So, and this is post-operatively also after the gas disappears 3 weeks later. This is a fourth case just to demonstrate that the use of intraoperative OCT with such a technique, especially if there is no much stain of the flap at the end at the time of the air fluid exchange, you can, of course, if you have the OCT, you can use it. You can see here how nicely it covers the flap, covers the hole. And also come now at the time of air fluid exchange, you can also use the OCT under air to at the end of the surgery to detect the where the flap is. This is under air, and you can see still the picture is nice, and the ILM is seen. The air is pushing the hole down as well as the ILM flap. This is it for now.
Okay. Okay. Thank you, Dr. Morazi, for this elegant presentation. I want to ask everyone of the panel, what gas do you like to use, AIRS, SF6, P3F8, and what is the time of face down position? We start by Dr. Morazi.
I use SF6 exclusively.
Okay. Face down position for how many days, how many hours per day?
Well, I know there is a lot of debate about this, okay? But I always tell the patient.
What do you tell the patient? What do you tell your patient?
I tell my patient that you have to have a face down position at least 8 hours a day for 1 week, because I know they will not ever stick to 8 hours a day, and they will not do it for 1 week. So if you do it for the first 2 or 3 days, that will be enough, I guess.
Okay. Professor Sharif. Professor Sharif Sheta.
I never use C3F8, mostly. Yes, I never use C3F8. Mostly I use plain air. Sometimes with larger holes, I use SF6 20%. The duration of the face down position, I usually tell my patient 6 hours a day for 5 days, interruptedly. And on night, sleep on the other side.
What is the way of sleeping on her face down position? The method, the way?
I usually explain to the patient that if you draw a line between the forehead and the tip of the chin, it should be parallel to the, so that I keep their hands close to their knees and in the position like sujood. It stays that like a minimum for 20 minutes and interruptedly, and at least 6 hours a day, at least 6 to 8 hours a day. And during night sleeps on the other side, avoid supine position. And this is only for 5 days.
Rahman Abdel Hadi, how many
actually,
hours per day for?
Actually, I ask the patient first if he can adopt a face down position, because some patients cannot adopt a face down position whatsoever. They have problems in their spines, heart problems, have performed previous open heart surgery. So if the patient can adopt a face down position, I use SF6. Normal 40% concentration, and I ask him to adopt a face down position for 3 days, because most of the studies have shown that the hole closes in the first 3 days, and I ask them to be in a face down position for most of the day. As for the method of the face down position, I tell them you can adapt a full face down position that your face is parallel to the ground, or if this patient is a slightly obese patient or has any problem with his back or spine, I ask him to do the chin should be touching the body, and he should be looking at his abdomen or at his lap, and this is enough. If you do this, the plane of the eye is parallel to the ground. If the patient cannot attain a face down position whatsoever, he tells me I cannot adapt any face down position. I have a problem with my heart, previous open heart surgery, a problem with the spine. I use SF6 with slightly expansile gas mixture, and this can close the hole for the first 2 or 3 days without any face down positioning. And a lot of studies have shown that face down positioning is not a must, except for the first day for a few hours. And I always use SF6, not air, and not C3 fate.
Okay. For Amir
Yes.
Ramadan, do you think you did the fluid exchange and the gas is filling the eye around more than 90%? Do you think that face down position is essential? Because if the patient is in a sitting position, the gas is covered the macular hole. Do you think it is essential face down position, or do you think it is not mandatory in the first days?
I think it's essential, especially if we are using the temporal flap or the inverted flap, and I need to ensure that there's good sealing of the macular hole by the dryness of the retinal surface.
Okay. Dr. Muhammad Hassan, how many hours per day?
I use the air in most of cases. In large macular hole, actually, I prefer 20% SF6, and I tell the patients to as much as he can of the hours in the day for 2 or 3 days post-operative.
Okay. Dr. Suka, do you sometimes use silicone in your cases of macular hole, or you think we have to use silicone in certain cases?
No, I don't feel silicone has a place in this type of macular hole, only in detachment cases associated with macular hole sometimes. Even recurrent cases, I don't feel silicone will add anything. Maybe we can argue differently, but I don't feel silicone does anything.
Children, you don't use silicone? If you have a case of child with macular hole, you don't use silicone?
No, I use SF6 20% for all cases. 1 week of trying to adopt face down position nearly all of the day, if they can. Of course, I tell them you omit times like eating, going to the bathroom, doing a minor errand, but as much as you can. The only tip, at night, they have a problem sitting, looking towards the ground. I tell them you can actually sleep on the other side of the surgery, the contralateral side, and rotate your head on the side of the pillow to look towards the floor by the edge of the bed. And they like it because it's looking down and they're actually on their side, actually. Most of the day, they have to actually support their forehead and the weight of the head. I mean, looking down and trying to touch your body, this is very damaging to your neck, and I feel it's really problematic. They need to lean forwards and have something to put their head on, to rest on, like a minor, office thing, side of the bed, pillow, whatever, but they have to support their head weight off the neck.
Okay, thank you, Ahmed. Professor Sharif, now we are going to discuss the stain. I want to ask you about which stain do you use, or the routine for you, and this question will be for the rest of the panel. Number 2, do you told us that you are not using under air, you are using in a fluid-filled eye. And the third, about you told us you do a cooling of the stain. You should tell us how do you cool the stain before injection, to which temperature do you use? Which stain under cooling of the stain?
Usually I use Preoperative. I think this is the best dye that can be used to stain the internal limiting membrane. I usually use it in a fluid-filled eye. I usually stop the infusion before injecting the dye. And as I've said, I just keep it for 30 seconds and just turn the infusion on. And usually the stain is stored in the refrigerator. So when it comes, it's cool, and this makes it heavier, and this makes it settles better on the surface of the retina. And if in doubt, after I wash the dye, I feel that the stain is faint, I can restain again. But this is my usual technique.
Okay, but Do you usually restain or just once and this is enough? Because sometimes the stain is not enough. I cannot identify the ILM by single stain. Sometimes I have to do it.
Especially high myopes, I usually use the stain more than once, but usually in idiopathic macular holes, usually once is enough. But if in doubt, you can just restain.
Dr. Mughazi.
I use the same, like Dr. Sharif just mentioned, the brilliant blue, and I use it under fluid, in a fluid-filled eye. I just stop the infusion before injecting the dye, and I keep it off until I'm sure the membrane is stained. I usually leave it for 1 minute, 1.5 minutes, depends, and I only restain in high myopes.
You put it in the refrigerator like Professor Sharif or...
I know this helps it settle down, but I don't do that. And I also use a membrane blue as a membrane duo sometimes. And I feel it's heavy enough that even without the refrigerator, it can just settle down on the surface of the retina.
Some surgeons use the combined dye, Triban with...
Yeah.
And I think it gives us better visualization or better identification of dye. Do you think it works, or do you think it is better to do like this?
I don't think so. I don't think it adds anything except if you have already an epimacular membrane that you want to stain as well. So it stains them both. But if you just have the ILM, I don't think it adds anything.
Okay. Rahmat Abdel Hadi, which stain under air?
I use the BBG stain. You know, Dr. Samir, myself and Dr. Magdi has introduced the BBG stain since 2005, when I used to get it and prepare it in the Faculty of Pharmacy before it even went commercial by Goider, the Brilliant Peel. You used to get it and prepare it, and it had marvelous outcomes back then. But nowadays I get the one. We get it from a company that performs Stigma Aldrich. This is a company that gets the BBG in powder form. I'm going to say it. I published this myself and Dr. Magdi in our first paper about BBG. We get the powder form from Stigma Aldrich. We use an electronic gadget in the Faculty of Pharmacy to get the grams. Then we mix it with saline. We pass it by a micropore filter. 20 micropore filter, and this is prepared in glass small tubes protected from light. And when you come to prepare it, you prepare it fresh by putting it on 10 cc's of saline. But nowadays we are not doing this since many years.
How do you sterilize this?
By the micropore filter, the passages by the micropore filter, it sterilizes it, and this is the way which Inada explained it in his first publication about BBG in 2003. But nowadays I use the one from Orolab. I think this is the best. It has the best concentration of BBG in the market, and I put it on a very small amount of 5% glucose. This makes it heavy, brings it to the back of the eye. I stop the infusion, stain under in a saline-filled eyes. I used to put it under air, but nowadays, or since many years, under with saline-filled eyes, leave it for 30 seconds to 1 minute. And I never restain except in myopic eyes, like I'm going to show in the next case. I stain many times until I get the best stain.
Dr. Suka, you're using the same way, or you have a different way?
Yeah, I'm doing now the same thing, but as a message to, let's say, beginners, people who want to start to peel the ILM, I prefer they start doing it under air for a few reasons. One, to ensure that staining is complete and as much as possible and covering the whole of the posterior pole. Second thing, injecting the jet of fluid towards the retina in a saline-filled eye can be a bit forceful. But under air, you usually have the ability to drip it, you know, at the tip of a flute needle, let's say, and you drip drop by drop within the air cavity over the posterior pole, not a jet of injection. So for beginners, I think it's a nice way to do it to ensure good staining. But nowadays, under saline is fine. I use whatever stain they have. You know, even when somebody like Ahmed Al-Hadi has one in the OR and says it's good, I tell them, bring me some of this. Another type of stain comes around, it looks good, it's fine. I don't have preference. They all stain well in my hands. Blue is fine. All blue stains look good. Under fluid filled cavity is okay, but I give it a lot of time, over 1 minute. I mean, I'm afraid of, you know, staining and then it comes out irregular, not so dark. 30 seconds can work, but if it's irregular, I'll then have to lose more time trying to restain. So I prefer going over 1 minute, 1.5 minutes to ensure it, and it looks blue enough. And I think it's easy. Staining, I feel, is no big deal.
Dr. Samir, can I comment on Dr. Suka? I used to help Dr. Suka more than 10 years ago when he started to do ILM peeling. He used not to do ILM staining at all.
Yeah.
He used to do an ILM peeling without stain, and I actually watched him a couple of times doing an ILM peeling without stain.
Yeah.
Dr. Suka, this is a question for you. Do you feel nowadays that this is, you still feel that the stain, when I talked to you about this back then, you told me that, in my opinion, that any stain can cause phototoxicity or toxicity. Do you feel this now? Do you still can try to do an ILM peeling without stain?
I can only do it without staining if I'm not fashioning a flap. If I'm just removing the whole of the ILM, I don't have a problem of removing it, no stain. I know I can just take it all off. And I think Moghazi shares this with me as an experience. But if you want to fashion a flap without a stain, it can fail. I mean, you can suddenly find that you're not sure where did you exactly stop, how far is the nasal edge, and so on. So I can't do it without stain. Blue stains have shown that they're not toxic. We have good visual outcome. I'm not sure if it was the length of surgery 10 years ago. I think it's the main factor, light toxicity probably. But definitely the new blue stains are not toxic. They're not causing damage. People are fine. Visual outcome looks good. Quality is fine. So of course, doing a flap of any sort needs a stain. I can't do it without stain now. It's tough.
Okay. So Muhammad Hassan, which stain do you like to use?
I use yes, I use BBG and I stop infusion just for half a minute or 1 minute. But in high myopic eyes, I usually put it in the refrigerator and make a mixture of the BBG and the glucose, and I stain under air. And I leave the stain for about 2 minutes in high myopic eye.
What is the goal of adding glucose to the dye?
It makes the dye more heavier, so it dips under air and makes a good stain and complete to the ILM. It gives me a better contrast in high myopic eyes, and I would like also to reply to Dr. Ahmed Abdelhadi about using the light. I usually use normal lights, but in high myopic eye, I prefer to put a chandelier light, and at the same time, I'm using the amber light in the other hand. It gives me a better contrast in the color difference.
Maybe.
Dr.
The glucose part, Dr. Samir, originally I saw it in Germany in 2004, and it was 20% glucose, not 1-to-1. The idea is using 5% glucose will make it heavier, but it's usually 1-to-1 dilutes the stain. It becomes very faint, unfortunately, but it's definitely heavier than water and goes under saline, very obvious.
I use 3-to-1.
Using 20%, 1-to-4, it becomes heavier in the area of the 5% again, it goes heavier and not diluting the color. But it's not available. 20% has become unavailable.
Dr. Ahmed, I would like to ask a question about how to prepare the mixture. Do you use a BBG 1-to-1 with glucose? And do you have blue or only BBG?
Yeah.
Which Ahmed? Ahmed Suka.
Dr. Ahmed Abdelhadi.
Ahmed Abdelhadi. Okay. I use it 3-to-1. Three portions of BBG and one portion of the 5% glucose. I used to use the 25% glucose, but there is a big issue now about, or a big issue since many years about its toxicity to the macula and so on. So I used the 5% glucose, and it did the job. I used 3 portions of BBG and 1 portion of glucose.
And you add also a triple blue or BBG only?
BBG, I always use BBG.
BBG only.
And this is not our idea. The dual stain is formed from BBG, trypan blue, and 5% or sorry, 4% polyethylene glycol, which is a glucose. So the glucose is something, or the sugar addition of sugar is something well known, that it keeps the dye heavy and it takes it to the back of the eye if you are using it on a saline-filled eye, not an air-filled eye.
Thank you. Thank you. Dr. Amir Ramadan, there is a safe way to avoid the trauma to the retina during injection of the dye. Is there a certain tips you use it, Dr. Amir Ramadan?
Yes, yes. I think the most important that when you are injecting, inject slow and steady, and inject away from the macular hole, because sometimes injection may enter under the macular hole. For myself, I prefer to inject under air, because when I inject under saline, I don't get a good contrast in a lot of cases. I don't know what's the benefit of injecting under saline only. If there is a problem with injection under air, or it's saving time, I don't know.
Okay.
Time.
Thank you. Thank you.
Can
there is a tip you can put, yes, Dr. Sharif, Professor Sharif. Sharif, go ahead.
Because I've seen trauma from the jet of the injection, enlargement of the hole, or the dye going under the macular hole, causing toxicity. So my technique is that I use a blunt 23 gauge needle connected to an insulin syringe, and I put like 5 ml in the syringe, and I use it in a fluid-filled eye. And actually, you make drippling, because there is no resistance with the wide bore needle. The resistance occurs with the narrow needles. So the wider the bore of the needle, the risk of jetting on the screen. And another tip, that if you can inject above the fiber optic line, you just
on the light pipe. On the light pipe. Sorry.
Light pipe. Inject a light pipe so that it ripples over the surface of the retina.
Okay. There is a certain injector which was designed by Eckert Klaus. I find it very elegant and very easy for injection.
A cheaper way is that I use the back flush needle. I just load the back flush needle with the dye and just push, and there is no stream at all. And so it's a very safe way of instilling the dye into the eye.
Okay. We have to proceed, and now Professor Ahmed Abdelhadi is going to talk about myopic macular hole. Dr. Ahmed, can you start your presentation about myopic macular hole?
Okay, one moment.
Share your screen, please.
Okay.
And after that, Professor Suka is going to present his case about myopic macular hole.
Bismillah ar-Rahman ar-Rahim. Can you see the screen? Okay. Yes. This is a 48-year-old female with 1 month's history of diminution of vision and metamorphopsia in her right eye. History of RK 20 years ago, phaco 5 years ago. The axial length was 34, and visual acuity was 560 in the right eye and 624 in her left eye. This is the OCT of the right eye. We can see the full thickness macular hole, and the left eye was okay. In high myopic eyes, like we have already heard that the ILM is thin, sticky, strongly adherent to the retinal surface. Also, it tends to break into several little sections rather than peel off in sheet during its surgical removal. Also, the debate about the extension of the ILM peel is a matter of controversy. For a successful macular hole closure, no clear guidelines regarding the minimum area of ILM peeling are available. Due to the adhesions between the ILM and the retinal nerve fiber layer, ganglion cell layer complex, the peeling maneuver might damage this inner retinal layers with consequently poor post-operative visual acuity. So thus, a smaller ILM peel is preferred in these cases. This is the surgery after vitrectomy. I used triamcinolone. In this case, I don't use triamcinolone routinely, but to ensure the cycloid has been removed. Also, I usually stain under saline, but in this I shifted to air. I stained. I didn't like the stain. I stained again under in a fluid-filled eye, I got this incomplete stain of the ILM. I tended to do an inverted flap, but I didn't get except shreds of the ILM from the temporal edge of the macular hole. I tried to do a temporal flap, a small temporal flap, then extended the peel 360 degrees. I didn't get a good ILM peel at the nasal edge of the hole or the superior inferior edge after two staining, one under air and one under saline. After extending the ILM, I stained again to see if there is any remnants of the ILM. I couldn't get any remnants, so I didn't identify any remnants, so I shifted to gas and left the patient on SF6. This is the picture 3 weeks post-operative with the gas in place and the hole closed with the OCT. The vision improved to 636 with minute central scotoma. Also, the patient had a central scotoma and she had to look to the side of this scotoma to get this 636 vision. But to my astonishment, that 6 months later, we can see an atrophic area. This is the whole 3 weeks. It's evident it's closed, but this is the whole 6 months later. There is an atrophic area around the area of the hole. And this is the OCT of the hole closed, but the vision dropped from 636 to 660 with this atrophic area. So 6 months, as you can see, with the OCT, you can get this closure, form of bad closure with the edges closed, but there is no continuity of the retinal layers in spite of the good closure in the early post-operative period. So I asked the panelists if anybody have encountered such a problem with myopic holes. I stained 3 times. I didn't take time with the ILM peel, and in spite of this, I got this outcome.
Okay. Professor Ahmed Souka, about myopic macular hole, your case, please.
Okay.
Your screen.
It can happen that you get this problem. I'm sharing it right now. That you get sometimes an atrophic area in a myopic case, but it can be related to simple myopia. Sorry, this is not the case.
I like to to believe this, and this is not my fault. But
I don't think it's your fault, but anyway. Okay, there you go. Okay, this is just a presentation of a simple myopic case. And this is, in my opinion, a simple case because you can see where the hole is. One of the problems I encounter in myopic cases is sometimes you cannot see the hole. And of course, I advise staining and restaining in high myopes because if you don't see well in these cases, the damage is major and the retina is not so clear as regards the depth. I mean, you try to catch an ILM and you feel that you are damaging the nerve fiber layer a lot easier in myopic cases than in a regular eye as regards axial length and stuff like that. This is a simple staphyloma case. It's not a very staphylomatous myopic case, but it does have a staphyloma, and you have to watch out while you peel and extend the ILM like this that you might hit the edges here because of the difference of elevation at the edges of the staphyloma. The forceps here can hit the retina, so you have to watch out that as you go further out towards the arcades, you have to elevate your hands a little bit and not hit the posterior pole. After fashioning the nasal side first, not because of a certain preference, but it seemed easier at the time, I tried to rotate around the flap I want to fashion eventually in the area of 2 disc diameters at least around the hole, and a bit of an extension of the flap further wider than that. Grasping in myopic cases is difficult. The retina doesn't have the same color as other cases. And usually you feel you're hitting more posterior. So you have to stay a bit more superficial than what you're used to while trying to catch the flap. Then I try to fashion it in, let's say, a Rexus type of thing, but as a flap, not a whole maculorhexis and removal of the whole ILM. I leave a lot of the flap at the beginning, no problem. The more of the flap I have, I feel it's better. I don't like to have it very small around the hole. I try to fashion my circle around, and then the important issue is that I pull it towards the edge of the hole. I leave only, let's say, less than half a disc diameter, maybe 1/3 of a disc diameter between the flap and the edges of the macular hole, as you can see here, and you leave it in place. 360 degrees, then the flap is too big, so I have to trim. Trimming is a bit tough because any vacuum near the flap will probably suck the whole flap off. Scissors is very difficult. So I use actually the cutter at a very low setting. I used to use 5 millimeters of mercury vacuum, and I think best now is 20, sometimes 25. And I can trim easily, as you can see, as much as I can. I fashion it the way I like, how much, how big, it's no big deal, using this 20 millimeters of mercury aspiration vacuum. And as you can see, it's effective to remove whatever is floating in the area, and I usually leave this size of the flap. I don't try to tuck it in, I leave the air to push it at the back of the eye, and the results seem fine. That's why I'm not changing the technique up till now. Thank you.
Thank you, Dr. Ahmed. Another question for Dr. Mohammed Moghazi. Do you have a certain tricks to identify the internal limiting membrane in cases of chorioretinal degeneration? Sometimes the macular area is whitish in color, so it is very difficult to identify the ILM. Ahmed Moghazi, can you tell us some tricks to identify the ILM in these cases?
Well, I think sometimes you can't really identify it, Dr. Samir. Sometimes you fail to identify the ILM in high myopic patients, especially those with posterior staphyloma, large posterior staphylomas and chorioretinal degenerations. And sometimes this happens during the surgery. You stain and restain and don't find the membrane. In those cases, I guess you need to use something else when trying to close those holes, like maybe an autologous retinal transplant. However, there are some currently in some of the new machines and some maybe on also the 3D systems that you can have some filters that can help enhance the dye, like the yellow filter. When you're using the beryllium blue with the yellow filter, this can enhance the visualization of the ILM. But mostly I rely myself when I catch the an edge of the ILM on the texture of what I am really catching. Okay, so this is very important. You don't only rely on the stain, but you also rely on the texture of the membrane that you're peeling. Okay, because sometimes, especially if you did not remove the posterior hyaloid, which usually is schitic in those patients, sometimes you're removing part of the posterior hyaloid and part of the ILM altogether. So I think illumination, filters, the use of filters, the staining and restaining, and also check the texture of what you're holding. If I may ask Ahmed Souka and Ahmed Abdelhadi a question, can I?
Yeah, sure.
Yes, go ahead.
Ahmed Abdelhadi, I mean, the case you presented has extensive chorioretinal degeneration, and there was no retinal detachment, and the retina is atrophic, and it's kind of, okay, it's a hole and everything, but I don't think that in those cases, I personally am really encouraged to do a surgery. Not because of the rate of recurrence or opening of the hole, but I actually might be doing more damage to this patient. I myself, I'm talking about myself, more damage to the patient. I might be creating another break. The patient can go into retinal detachment sometimes. So I actually, in those patients with extensive chorioretinal degenerations, very large staphylomas, and the flat retina, an open hole, to me, it doesn't add to the patient's vision if I close it or not. Do you agree or disagree with me?
Actually, I discussed this case with you. You don't remember? I don't know if you remember when we were with each in Barcelona, and I told you this is the last case I'm going to do of myopic macular holes, because I didn't feel that I added for the patient anything. I felt that the patient, if she was left with the macular hole, she would have ended with this 660 vision. So I quite agree with you that in this very long axial lens, small holes, even if the patient is coming with a definite complaint, sometimes the rexus, the macular, the ILM peeling, even if I'm a good surgeon, I can take time in this ILM peeling. So I quite agree, Dr. Mohammed, that when I get a patient like this again, I will be very skeptic about doing surgery, or I will not offer surgery except if the patient is definitely complaining, insisting. But my first thought is that she should not do surgery and I should wait. So you're quite right.
I disagree. I used to think this way and told lots of patients we shouldn't do, you want to improve. But after this new multi-layer technique, and some patients who would have liked to try it, and the good outcome, last 2 or 3 years, I'm doing each and every patient like this, and 90% they improve, and much more than I tell them. I tell them we'll have at least in the area of 2 lines improvement. Most of them exceeded to 3 and 4 lines. So no, it's working, but it's tough. Stain a lot, good multi-layer thing, it does enhance vision. So I changed my mind. I'm doing them now.
I don't think Dr. Mohammed is debating the factor that you're not going to do an ILM peel or that the hole is not going to close. The hole is going to close, but the burden of the surgery.
Totally understand.
The burden of the surgery itself. Yeah. What do you think, Dr. Samir?
Dr. Amir Ramadan, you are with me? Dr. Amir.
Dr. Amir Ramadan.
Yes, I'm present. Yes.
Okay. Okay. In these cases, we have cases of very long axial length. It may reach 35 millimeters. If there is any tricks, so can we can reach with these forceps or our forceps till the macula?
Sometimes it's very, yes. I don't have a lot of long forces. Sometimes that I remove the trocar so that I can reach the macular hole with my instrument without distorting the cornea or my view. Still, for these cases, if the osteo's atrophic edges of the macular hole, I would not operate. So I will not close, even if I opinion.
Okay. So Muhammad Hassan, do you do trimming in your cases? Trimming of the flap?
Yes, in multi-layered flap, I usually trim with low vacuum settings of the cutter. And I would like to say regarding doing surgeries for high myopic eyes, I agree with Professor Moghazi for this. Sometimes you have atrophic holes in a very high myopic eye, and the visual acuity is just 1 meter. The edges of the hole is extremely atrophic and scarred. I don't prefer surgeries for such cases. It can close, yes, but without any visual gain. So I think surgery is not beneficial for such cases. Also in high myopic eyes, if I stained multiple times, I am not getting enough stain, and I know that I may face a contradiction for this by the audience. But if I'm not able to stain the ILM and take a sufficient multi-layered flap in high myopic eyes, I shift directly to autologous retinal transplants. And in the past few months, I did about 5 or 6 cases, and I gained a reasonable vision.
Okay. We have to proceed. Now I'm going to present my case about retinal graft. I'm going to show my technique about retinal graft. As we know, this technique is a new technique which was proposed by Tamer Mahmoud, and we do it in cases of refractory macular hole, cases which was operated before and no success. So we start, usually I'd like to do it under perfluorocarbon in order to control everything. And I start to delineate or mark the area where I'm going to do retinal, take the harvest the retinal graft. We start by laser photocoagulation and then diathermy to avoid bleeding from the retina. It should be taken as periphery as possible, outside the equator as much as possible, upper temporal or upper nasal. And after that, with the help of the forceps, we can separate this, harvest this part of the retina very slowly. And as we see, it is under the perfluorocarbon. The perfluorocarbon is very helpful to prevent this graft from being escaping or being lost in the fluid. There are three rules during this procedure. The first rule, you should keep the nerve fiber layer in the same direction. For this reason, I am using two end gripping forceps to maintain the direction. Second, avoid flipping of this graft upside down. Third, you should be edge to edge on the nasal side, and it should be overlapping on the temporal side. I'm using Thanos scraper in order to spread this retinal break, and this is under perfluorocarbon. I tried before in a fluid-filled eye, but actually I lost the graft because it escapes in the fluid and I couldn't find it in the procedure. So the perfluorocarbon actually keep everything in place and stable and stabilize it during the procedure. Then I'm doing a fluid exchange, leaving a small bubble of perfluorocarbon and injection of silicone. Then I'm starting to aspirate the perfluorocarbon very gently, and the port of the scatter should be away from the graft to avoid aspirating this graft, and should be very slowly. I am aspirating this perfluorocarbon under the silicone oil. And actually, this procedure, as you can see, this picture showing the macular hole, which has been operated before, and the lower photo showing after the ILM, the retinal graft. Also, I'm going to proceed to a human amniotic membrane. This procedure was published in October 2018 by Senzo Rizzo, and we are using the human amniotic membrane. And to cut it, we are using the dermal punch. We have 2 and 3 and 4 millimeters dermal punch. We start to fashion this graft and holding with the forceps, and we can put it on the surface of the macular hole, but sometimes it is lost with and go away. So in some situations, or recently, I'm tucking this under the edge of the macular hole. Here is the human amniotic. Should be the glistening side should be anterior, and the other side should be toward the choroid, and just tuck it under the retina very gently and very smoothly, avoid damage of the retinal pigment epithelium. And you should not tuck it 360 degrees. You can tuck it in certain quadrants, and the rest of the quadrants is not mandatory. And this is followed by fluid air exchange. Here is OCT pre-op. As you can see, the macular hole first week. In the second week, we are going to see that the retina is creeping over the amniotic membrane, and at the 8th week, as you can see, complete reconstruction of the retinal nerve fiber layers. But the main problem which I am facing in this case is that the amniotic membrane stays forever. It doesn't go. And this actually affects the visual outcome. Visual outcome doesn't improve like the inverted ILM or the other techniques, temporal IM or whatever. Second, it stays forever, and leading to field effect for the patient. So you should select your patients in these cases. Sorry, we have to proceed because we are losing time. Dr. Ahmed Souka, can you proceed for your presentation about adherent posterior hyaloid phase? Ahmed.
Dr. Souka. Yes.
In a pediatric case, around 7 years of age, is supposedly diagnosed as FEVR, FEVR, familial exudative video retinopathy, with peripheral retinal changes, minimal traction points, blood vessels, and tracted areas. However, the main cause of the surgery was that he had a very wide macular hole that I believed was making this eye looking much less vision than the other eye. As you can see here, after staining, you could see that there was a very adherent posterior hyaloid, and you can see here how the posterior hyaloid peeling, which was lightly stained at first, was actually causing the ILM to be peeled due to the pull, as you can see the triangular area here that was shown in the last few seconds. You can see here, this is still the posterior hyaloid having some bluish stain with the ILM stained underneath. And you can see how removing it pulls on the ILM in some areas here and causing a lot of traction on the surface of the retina, although it's being peeled by a forceps, not like a general suction of the whole area as we're used to. So yeah, of course, we know that pediatric cases have this adherent posterior hyaloid. However, this was a little bit more adherent in my opinion. Furthermore, peeling the ILM itself, it looked to be more adherent than normal ILM. Here you can see that it started an ILM peel and ended with another layer of the posterior hyaloid, very sticky, very adherent, very difficult to peel. You're actually holding it with the forceps, and you can see the retina being pulled. Now going back to the ILM, trying to complete a flap around the macular hole. And you will see as we proceed how adherent the ILM was to the surface of the retina. You will see here that it's basically pulling the retina off its place. You can see here, yeah. So a flap is fashioned, again, to the edge of the hole, not furthermore, not peeling it off the hole. And eventually, in the end, I will trim it with the cutter with a low vacuum in the area of 20 millimeters of mercury. You can see here widening the ILM peeled area, and look how the retina is being pulled just by the ILM peel. So definitely these cases have an abnormal adherence of both the posterior hyaloid and the ILM. The flap, as you can see, is fashioned around the edges of the hole, a bit wider in some areas. However, with the cutter, low vacuum around 20 millimeters, you can trim it and leave a minor area of the flap only. And this is one of the very rare cases in ILM flaps that did not close. It was only a bit narrower, the hole. It's not as it looks now, but it did not close. And this is a recent case, and the patient's only 3 weeks now, maybe 4th week this week. And the OCT post-op is not yet done. It will be done within the next few weeks. But I assure you that the hole did not close like what we're used to in ILM flap cases. Thank you.
Okay. Now Professor Moghazi is going to talk about combined inversion of epiretinal membrane and ILM. Moghazi, can you share your screen, please?
Yes, sure.
Sorry, we have to proceed because we have a lot of presentations still.
Yeah. Well, these are special situations actually when you have when you stain. This is a case with epimacular membrane. It's obvious, and the full thickness macular hole. And after staining, you can see that the ILM is stained and it's adherent to the overlying epimacular membrane. So you cannot separate them from each other. So in such a case, I guess you can use the epimacular membrane to close the hole as well. Of course, you're gonna have to remove the epimacular membrane from the rest of the macula. But in such cases, and we all face those cases in the practice, you cannot actually separate the ILM from the overlying ERM. So in such cases, I guess it's not a bad idea to use also the ERM. I mean, if we're using autologous retinal transplants and if we're using the amniotic membrane like Dr. Samir just showed us, why not using the epimacular membrane in some cases that you're faced with this situation? This is the post-operative picture, and the hole is closed, of course, with some surface corrugation, but the hole is closed and the visual acuity has improved. This is another case. This is a fluid-filled eye patient. I did her vitrectomy like 7 years ago, and she presented recently with a retinal detachment of the large hole, Previously, she had also posterior uveitis, so you can see the retina is a bit ischemic. And you can see here, there is a membrane, kind of a proliferative membrane over the surface of the retina. I tried staining, but nothing was stained. So I decided, why not using, it's a very large hole. So why not using the that membrane, actually, that proliferative membrane, to close the hole? This patient originally in the original surgery had an inferior retinectomy, like you can see here, because the retina was really short. So that's all I found on the surface of the retina. Of course, we can argue that we can remove the membrane and then do an autologous retinal transplant. But I just wanted to try this because I know that the hole is very large. You can see it's very large. And she won't have any central vision anyway if I use an autologous graft or if I use this. And this was handy. I mean, this was there. And I use it to close the hole. Also, I did it in an inverted fashion. And you can see here, this is post-operatively in the presence of silicone oil. The retina is flat and the hole is closed. And this is a few months later after removing the silicone oil. There is a large scar showing the hole itself, but the retina is flat and the membrane actually shrunken. That's what I wanted to show you regarding that special situation that sometimes you're faced with when you're operating on such different scenario of cases.
Okay. I'm going to proceed with my presentation. I'm going to show you, I'll share my experience with you. There is a technique which was proposed by Dr. Meyer in Germany about macular detachment. As we all know that there are a lot of complications of ILM peeling and the inverted ILM flap, starting by macular toxicity and the macular toxicity.
Dr. Samir, unmute.
Samir, we can't hear you. Dr. Samir.
Okay, okay.
Nice.
It's okay. It's okay. Now can you hear me? Okay.
Yes.
There is another complication like field changes which had been discovered by microperimetry. Some field which is a swelling of arcuate retinal nerve fiber layer, as you can see here. All these are complications of inverted, and if you touch a ILM, there is great possibility of development of these complications. Downfill, it may develop, which is a dissociated optic nerve fiber layer defect. Dimples also may develop due to ILM peeling. Foveal displacement has been discovered in few cases, and ganglion nerve fiber reduction of the thickness has been discovered also in these cases. And also paracentral retinal holes, one of the complications of inverted ILM. So why don't we use a technique without touching the ILM in the macular area? So I start by staining. I'm using the stain under air usually. As you can see, this is a fresh macular hole. It is not a recurrent case. And start to detach the macula using the 41G cannula and injecting the saline under the macula to detach the macula. This helps that the macula reposition and go back again to its place. And why not to leave the macula, the ILM in the macular area in peace and don't touch it, and start to take the ILM in an area away from the macular area, like this area, which is around at the superior arcade. After fashioning this ILM, I am dragging the ILM toward the macular area with the Thanos scraper. I didn't touch the ILM in the macular area, as you can see, and start to move the ILM till it reaches its final destination. And I started to tuck the ILM. My goal for macular detachment is during packing of ILM, I'm moving in a fluid. I am not damaging the retinal pigment epithelium. For this reason, I am doing macular detachment, which was proposed by Dr. Meyer. This is the macular hole, and this is after 1 week. As you can see, the ILM inside the macular hole. Here is after 3 weeks, as you can see, and the lower photo is the after healing, and you can see complete reconstruction of regeneration of all the layers of the retina. Now I'll stop sharing, and Dr. Abdelhadi is going to talk about traumatic macular hole.
Okay, this is 15-year-old girl fallen from height from the third story, left visual acuity between 0.05 and 0.1 3 months ago after her accident. The rat eye was 6'9", clinically free. It was actually a very large hole, as you can see in the vertical and horizontal OCT cuts. And this is a hole with some changes in the whole center. In my opinion, it's very important for a traumatic macular hole to do something to check the retinal pigment epithelium around the hole. If I get what we call a traumatic maculopathy, a large area of RPE changes around the hole, which involves the whole macula, I don't operate, because this is an area of positive scotoma, and even if the patient, the hole closes, this positive scotoma will not improve. So a good way to check the RPE is to do a fundus autofluorescence. As we know, the fundus autofluorescence between the 5 and the 10 degrees should be better than the central area where there is loss of fundus autofluorescence, and this is the case here. Of course, in the base of the hole, there is loss of the RPE because of the chronicity. So at least the area around the macular hole has a good function, and this encouraged me to go on with the surgery. And this is the surgery after core vitrectomy. She was a young child, so I had to make sure that the posterior hyaloid was detached. I used triamcinolone, and after detachment of the posterior hyaloid, I removed the excess triamcinolone and the excess BBG. And my routine nowadays is a temporal flap. So I fashioned a temporal flap, first delineating my boundary, as Professor Mugazi showed. Then I started to do the temporal flap, a large one, to avoid its displacement. Why not do a temporal flap, bilayered temporal flap? So this was done for this patient. And of course, after this, finishing my vitrectomy, screening for any breaks, shifting to air, and putting the patient in SF6. This is the lens of the patient, which was stained with BBG, and this, of course, was gone after surgery. She was 360, now she's 660 only, sorry, between 560 and 660. She's 660 now, 3 weeks later, with the hole closed, and we see a glial plug and the remnants of the ILM. And this is 8 weeks later with a more hyper intense glial plug. And as you can see, this contractions of the ILM in the nasal area, but the visual acuity continued to improve to 624. To compare, this is before surgery, just after surgery, and this is 8 weeks after surgery with the contraction of the ILM and the glial plug in the center of the hole. And as you can see, this is the OCT just after surgery, and the OCT later on. And this is the end of this case.
Okay. Dr. Mohammed Moghazi is going to his presentation about inverted ILM without drainage. Please proceed, Mohammed.
Okay, so in cases of retinal detachment complicated by macular hole, I know the classic technique is used to initiate the flap and then use PFCL. Actually, I find that you can actually initiate the ILM flap and the inversion without need to drain the retina under this the central area. And sometimes just do fluid exchange through the hole or a peripheral break if found. And I think it's easy to do that. This is maybe a more clear case. Again, there is retinal detachment. I used to, in this case, I drained through the peripheral break, and after staining the posterior hyaloid and staining of the ILM, again, the retina here is detached, the retina is high, but the flap can be initiated. And again, also using a temporal flap here, while the retina is attached, without the use, again, of PFCL at the end, just air fluid exchange. The peripheral break is flat and lasered, and the hole is closed by the ILM flap, which can quite nicely close the hole and prevent the migration of fluids under the retina, allowing the RPE pump to function. You can see here, air fluid exchange. The retina at the posterior pole is still detached, but the hole is closed by the flap. And this is the post-operative picture just 1 week after the surgery. This is another case with a similar technique, just to show you more. Again, a peripheral break to reduce the amount of fluid under the retina. The membrane can be fashioned, the flap can be fashioned without flattening the macula, and it can be inverted. This is, of course, high speed. In this case, I could not invert it temporally. So I just did the all-around inversion of the central ILM, again with the retina detached, and then trimmed, and again air fluid exchange through the peripheral break, and the retina at the posterior pole. This is the tanoscraper just making sure it's covering the hole, and the retina is detached like you can see here. And this is again 1 week after the surgery was complete resolution of the subretinal fluid and the retinal detachment. So it's it's doable. Thank you.
Okay, thank you, Mohammed. With the last presentation by Professor Ahmed Abdelhadi about diabetic macular hole.
This is a hole in a diabetic patient. As we all know that holes in diabetic patients in peripheral diabetic retinopathy, it can develop in eyes with or without fibrovascular proliferations. The structural changes, treatment, and outcome of macular holes in diabetic retinopathy without fibrovascular proliferations are similar to those in idiopathic conditions. So to share this case, this was a 49-year-old female, non-diabetic history of PIP-OU for PDR 3 years ago, recent drop of central vision 1 month ago in her right eye. One examination, right eye was 0.2, nuclear cataract, old laser marks, and a full thickness macular hole. And this is the OCT showing the full thickness macular hole. And this is the surgery. We went with the usual manner. The video is not working.
Stop share and share again.
Okay.
Stop and try it again. Still not working?
There's a question from the audience to Dr. Mohammed Moghazi. May he answer it until I see what's wrong with the presentation from Dr. Amr Raouf. say, Dr. Muhammad, why don't we use also nasal flap routinely with temporal?
Because if you do it, you will lose the advantage of the temporal flap. You don't have the nasal reservoir of the flap, and you will induce damage at the papillomacular bundle. So it's as if you're inverting the whole membrane.
Okay, to Dr. Shita from Muhammad Hormel, is there any toxicity of the dye after restaining on an already peeled area? Do you feel this?
Well, Dr. Shita already answered.
There is no.
He answered this question, and he said there is no toxicity about restaining. It's working, Ahmed, or you can?
No.
Okay.
We can finish questions and.
I'm going to ask a very important question. All the audience are waiting for it. What are you going to do if you have a macular hole first surgery? And what is the scenario if you are going to operate in a recurrent case and a mega hole? I mean by mega hole, a huge macular hole around 100 microns. We'll start by Muhammad Hassan. So Muhammad Hassan, can you tell us your scenario about macular hole first surgery and recurrent and mega macular hole?
Yes, for a first hole surgery, if the hole is small, I do the routine maculorex till now. If the hole is large on OCT, I use the inverted flap technique. In large macular hole or recurrent macular hole, in large macular hole, I use multi-layered flap technique. But in a mega macular hole, I do an autologous retinal transplant from the first time.
Dr. Amir Ramadan, what's your technique?
Well, my technique for the macular hole is the inverted flap technique, either the temporal or the original inverted flap technique. For the recurrent macular hole.
What you do, the temporal or the inverted ILM?
I started using temporal recently, but most of the cases were the usual technique. And it also works nice, no problem with it. For the recurrent, it's difficult to have a definite successful technique. I try graft, but it usually doesn't work.
Okay. For huge macular hole for the first time, or for around 1,000 micron or something like this, do you operate on it or you?
I didn't operate for that size of a macular hole, but I think I would do the large temporal flap to cover it.
Okay. Dr. Suka, what's your scenario in these cases, in these three situations?
Well, all types of macular hole, even very large ones, I give the inverted flap a try. I do it temporal, nasal, and all around. I would make a very big flap as regards the size over the hole in very large holes. Small holes, moderate holes, whatever, all of them same technique. The real problem is when you have a failed closure of the hole after you do this flap technique. At this point,
you don't have an ILM.
Yes.
Yeah. Even ILM grafting and stuff like that, they all fail in my hands. I didn't see good results up till now in a certain technique after you fail enclosure using the inverted ILM flap as a first surgery. I am searching for the best possible outcome up till now, but what I would do, I would probably consider the retinal graft nowadays and amniotic membrane if it gives good results. The retinal graft I've tried once in a very bad case, and outcome looks good anatomically. Vision quite similar, still in between 660 and 636, but she did see similar pre-op. So I really find this a very tough question, and I'd like to know if somebody has the answer to this one, actually.
Dr. Samir.
Yes, Amir.
Sometimes when the failure is a small macular hole, when you enter and just milk its edges and inject gas again, it works.
Yes, this is what I'm going to say.
Yeah, but it's quite uncommon for small holes to fail, and usually they close. And I agree we can do another, let's say, graft or flap of whatever remnants and milk it. But if you have a wide hole that didn't move, didn't show any response, I don't know what to do in this case, actually.
My experience in
Still
retinal
failing.
graft, actually, retinal graft acts as a plug. It closes the hole, but this part it doesn't work. But actually, when you make this plug, there is some sensory detachment around the macular hole, and this sensory detachment disappears. So the patient feels some improvement due to disappearance of this sensory detachment around the macular hole. Abdel Hadi, what your scenario in these cases?
Can you remind me about the different cases? The small,
macular hole first time, recurrent macular hole, and you lost your ILM, mega macular hole.
Macular hole, inverted flap, or recently temporal flap. Mega macular hole, very large temporal flap. I haven't done a retinal graft for a macular hole. I've done a retinal graft for a posterior break in a penetrating trauma patient, and it closed the posterior break. And I felt that this posterior break was going to do problems. I don't know the visual results. Maybe Professor Samir, you could comment on this. The visual results about peripheral retinal grafts at the macula. We are not closing the hole to close the hole. We are closing the hole to gain vision. So for a large macular hole, a temporal flap, and I have no experience on retinal grafts or amniotic membrane grafts for mega holes. For a recurrent macular hole, if I've done the surgery myself and I've done a temporal flap or a inverted flap, I have no ILM. If a temporal flap, like Dr. Moghazi showed, I can do a nasal flap. But the inverted flap technique, where I've done an ILM peeling 360 degrees, I can do a free ILM flap. I can extend the ILM from the edges of the previously peeled ILM, and I extend this hinged flap to the foveola. But like Dr. Suka said, it's very rare for, in my hands at least, for a hole not to close after an inverted, properly done inverted flap or a temporal flap.
Okay, Dr. Moghazi, your experience in these three situations.
Well, I do temporal inverted flaps.
I would like to know your experience in retinal grafting.
Okay,
because you did a lot of cases.
For a primary idiopathic macular hole, or any kind of hole, I do a temporal inverted flap all through. It doesn't matter what type of underlying pathology. For a recurrence, again, if it's a temporal flap, I can use the nasal to close it. If I don't have, sometimes you stain and you don't find any residual ILM. In that case, that's I do the massage of the edges, and especially in those cases, the edges are usually a little bit detached, or there is a cuff of detachment around them. I do a bit of a massage with the Tano scraper, a blunt Tano scraper, or maybe the soft tip flute cannula, and usually they close. For mega holes, if I see a good visual potential in those patients, I would use the autologous retinal transplant. Okay, but like you said, and I totally agree, and when I discussed this with Tamer Mahmoud, I told him, you present cases with a lot of visual improvements after the technique. But the thing, to my opinion, to my mind, I think like you said, there is an edge, or there are cystic spaces all around the hole, and they collapse. And so this very small cuff of detachment and the edema of the edges of the hole, once they collapse, the patient feels some improvement of central vision, but not actually in the center of the fovea. And I had an experience with autologous retinal transplants in several cases. I have done microperimetry, and to my surprise, that there is actually a signal coming from the center of the fovea. And I have the microperimetry and the multifocal ERG to prove it. So probably there is some kind of regain of function in those patients, but I don't know how it works. But this is the only indication for me at the moment to use the autologous retinal transplant, which are the mega holes with good visual potential eyes.
Okay, my experience in this case is actually I'm using either the inverted ILM flap or the temporal ILM flap in first surgery. In cases of mega holes, I'm using the retinal graft, and as Muhammad said, and we all agreed that there is a kapha fluid which disappear after a time. But actually, I have good visual potentials, but actually it takes a lot of time. It may take more than 1 year. We don't gain the maximum vision in the early days like inverted eyelid flap or the temporal flap. No, it takes a very long time. I think something is going on, there is a sort of, I don't know, but there is improvement, definitely improvement of vision after a very long time. At the end of this session, I would like to thank all the participants and the speakers, starting by Professor Shif Sheta from Cairo University, Professor Dr. Muhammad Moghazi from Ain Shams University, Professor Dr. Ahmed Abdelhadi, Professor Ahmed Souka, Professor Amir Ramadan, and Dr. Muhammad Hassan from Alexandria University. And I'd like to thank all the audience for their participation and till that time. Hope you to see you soon later. Thank you for you all.
Thank you, Dr. Samir, for great moderation, and thank you for all the audience.
Thank you. Thank you, Dr. Samir.
Thank you.
Thank you.
Hello, doctor. Greetings from Orchidia Pharmaceutical. I hope you, your family, and all your beloved ones are safe and in good health. I'm going to talk about dry eye patient, especially who is associated with itching. Orchidia offers the integrated solution from Orca-P-Post and PolyFresh Extra. Orca-P-Post is anti-aging and anti-allergic agent, which is not only has exceptional antihistamine effect, but also has a novel special mechanism as anti-aging agent by inhibiting nitric oxide secretion at nerve endings. The second arm of our solution is PolyFresh Extra, which is a unique combination that gives extra hydration effect and balancing the tear film osmotic pressure, in addition to the anti-inflammatory effect of glycerol. Thank you for your time.
شكرا مهاب، شكرا شادي.
Thank you, Dr. Samir. شكرا دكتور.